Allergic conjunctivitis. Acute allergic conjunctivitis. This is contact hypersensitivity due to exposure to allergens. Causes include hay fever, which is seasonal, animal dander, and topical drugs. There is immunoglobulin E mediated immediate hypersensitivity reaction, acute anaphylactic reaction due to mast cell degranulation and histamine release, chemosis, itching, dermatitis, and eosinophils in smear. Allergic conjunctivitis, vernal conjunctivitis, or spring catarrh. This is bilateral recurrent immunoglobulin E hypersensitivity reaction of adolescents with history of atopy. It is caused by allergens, which may be exogenous as pollen and animal danders. Here the condition is seasonal. Or endogenous, where the condition is aggravated by exposure to ultraviolet B rays. Vernal conjunctivitis is more common in keratoconus patients and male sex. The conjunctiva shows chronic papillary hypertrophy up to cobblestone formation. The papillae are flat-topped with regular size. They occur in upper tarsal conjunctiva more commonly than lower. The upper fornix is characteristically free, and giant papillae may develop in severe cases. Microscopically, there is epithelial hypertrophy, then atrophy. Fibrovascular papillary core proliferation with perivascular diffuse infiltration of lymphocytes, plasma cells, mast cells, and numerous eosinophils and basophils. Hyaline degeneration of stroma is also present. Thick ropey whitish discharge formed of mucus, epithelial cells, polymorphs, and a large number of eosinophils is met. Limbal vernal keratoconjunctivitis is more common in blacks and shows thickened gelatinous appearance of limbus with vascular injection. Tranta dots appear as grayish limbal papillae with white spots on top. Intra and subepithelial collection of eosinophils and epithelial cellular debris associated with marked epithelial proliferation occurs. Corneal involvement in spring catarrh. Pannus formation with destruction of Bowman's membrane. Keratitis epithelialis vernalis of Topke. Central corneal infiltration with grayish-white discrete epithelial dots, stained with rose bengal. It is common with palpebral form. Vernal ulcerative keratitis. Non-infectious epithelial ulcer. Transverse oval ulcer. Affects upper cornea with stromal opacification. Giant papillary conjunctivitis. This is a condition that is similar to vernal catarrh seen in soft and hard contact lenses wearers and post-enucleation ocular prothesis. It is an immune-related response to repeated mechanical trauma, hypersensitivity to foreign material itself, or dry eye. Microscopically, there is accumulation of mast cells, basophils, and eosinophils. High levels of immunoglobulins E, G, and M. This may represent a cell-mediated hypersensitivity reaction. Phlectenular conjunctivitis is local corneal or conjunctival inflammatory condition. It is a delayed hypersensitivity reaction to bacterial proteins like the cell wall of Staphylococcus in blepharitis, Candida albicans, pneumococci, and Koch-Weeks bacillus. Association to tuberculoprotein and intestinal parasites like Ascaris lumbricoides and Ankylostoma duodenale is of historical interest. The condition is unilateral. A conjunctival phlecten is present. 2 to 3 mm whitish inflammatory nodules on bulbar conjunctiva surrounded by a zone of dilated vessels. Necrosis with epithelial ulceration. Healing occurs with no fibrosis. Corneal phlectens, superficial phlecten, in front of basement membrane. Ulceration results in fascicular ulcer, which is moon-shaped and tends to move centrally across the cornea with a leash of parallel vessels. Deep phlecten, which is deep to basement membrane. Destruction of anterior corneal lamellae and basement membrane occurs and results in deep and superficial vascularization. Phlectenular pannus, vascularized granulation tissue affecting any part of the cornea, thin with vessels straight and deep to basement membrane. Microscopically, the stroma shows lymphocytes aggregation with endothelial proliferation of neighboring blood vessels. Epithelial shedding results in ulcer formation with polymorph nuclear leukocytes, plasma cells, histiocytes, and mast cells infiltration. Local thrombosis and edema occur. Corneal affection may result in a characteristic wedge-shaped corneal scar. Ocular cicatricial pemphegoid. This is chronic cicatrizing conjunctivitis of autoimmune nature. It is more common in middle-aged females. It is cytotoxic type 2 hypersensitivity with autoantibodies directed against basement membrane. Autoantibodies activate complement, resulting in breakdown of conjunctival membrane. Other mucous membranes, like that of mouth, oropharynx, genitalia, and anus, are affected. Pathology: conjunctival hyperemia, edema, and ulceration. Various stages of ocular cicatricial pemphigoid. Stage 1: subepithelial fibrosis. Stage 2: bullous conjunctivitis, loss of goblet cells, shortened fornices. Inferior fornix less than 8 mm is suspicious. Stage 3: symblepharon formation. Stage 4: restricted ocular motility from adhesions between eyelid and globe. Microscopically, there is destruction of conjunctival basement membrane, chronic inflammatory cells, C3, immunoglobulin G, immunoglobulin M, and/or immunoglobulin A localized to conjunctival basement membrane by immunohistochemistry. Ocular cicatricial pemphigoid may be complicated by goblet cell destruction, conjunctival keratinization, fibrosis resulting in trichiasis or entropion, corneal vascularization. Differential diagnosis of cicatrizing conjunctivitis: infectious conjunctivitis, like that caused by trachoma, adenoviral conjunctivitis, and streptococcal conjunctivitis. Autoimmune conditions: sarcoidosis, atopic blepharoconjunctivitis, Stevens-Johnson syndrome, ocular cicatricial pemphigoid, and graft versus host disease, which is a severe keratoconjunctivitis sicca. Trauma: